I'm Ian Blunt. I'm a Senior Research Analyst at the Nuffield Trust, and I'm going to talk about a piece of research we've undertaken into emergency admissions in the last 5 years. Why emergency admissions? An emergency admission is one which is unpredictable and because of clinical need. There's a range of emergency care services available, and only a small minority of these will result in hospital admissions. An emergency admission to hospital is undesirable. It's very distressing for the patients and their family. It's very costly to the NHS. It's recorded in routine data, and we'll see why that's important in a minute. But most important of all, it's thought to be increasing in number. Are emergency admissions rising? The very short answer is yes. The bar chart on the left of the screen shows the number of emergency admissions in every year since the mid-90s. And the 5-year period we're looking at is highlighted in red. We can see there's a steady growth, and in the last 5 years emergency admissions have risen by 11.8%. That's equivalent to 1.3 million extra emergency admissions over the 5 years. The rise in emergency admissions has been much discussed, and possible reasons presented for it are the ageing population of England, increased public demands on healthcare, potentially more illness, and decision-making becoming more conservative amongst clinicians because of fear of litigation, the influence of central policy, and changes in the way urgent care services other than acute admissions are managed, and the public perception that accident emergency is the only place to go when you require urgent care. Most of the evidence that supports the reasons we saw in the previous slide is anecdotal. The aims of our research was to use quantitative analysis to explore patterns in the rise of emergency admissions, highlight characteristics of some of these excess admissions, and describe some of the variation between hospitals and local areas. This work uses the Hospital Episode Statistics database, which is a large anonymised database of patient-level information that tells us about each emergency admission in each month for the 5-year period from April 2004 to 2009. Is the increase unique to emergency admissions? What we're looking at here is the utilisation rates for various types of healthcare since the mid-90s, as well as emergency admissions, which are shown in the purple line. We also see, for example, accident emergency attendances in red, calls to ambulance services in orange, and GP consultations in light blue. The important thing is that we see the same upwards trend in all types of healthcare utilisation. And the question is, are we becoming more ill, or are we just more inclined to seek healthcare? If people are becoming more ill, we might expect to see that related in the number of deaths. What we're looking at here is the number of in-hospital deaths following emergency admission for each month in the last 5 years. It's the blue line. And we can see that it's got a very seasonal effect. People are more likely to die in the winter, but it's also gradually reducing. Of course, the types of cases a hospital might see will change year on year, and we can adjust for this by taking into account the age, the sex and the diagnosis of the patient to create an expected number of deaths based on the levels we've seen in 2004-2005. That's the dotted line on the chart. We can see that the number of observed deaths becomes increasingly less than the number of expected deaths as time goes on. Lastly, the light blue line on the chart shows the percentage of emergency admissions that end with death, and this is also reducing. So across all 3 measures, deaths following emergency admission are falling, which suggests the cases that receive emergency admission are becoming less severe. Has there been a change in the length of time people spend in hospital following emergency admission? In this chart we see the number of emergency admissions categorised by their length of stay, or emergency bed days used, for each month in the 5 years. And we can see that all the growth is being concentrated in those top 2 lines. That's the people that are staying less than 24 hours and just 1 day. We also know that the increase is concentrated in people who are being admitted via accident emergency departments rather than other types of emergency admission. Is the increase related to age? We know that your chances of emergency admission increase rapidly with your age, and we also know that England's population is ageing. If we use the same standardisation technique as we saw previously, we can create an expected number of admissions based on age and sex and 2004-5 rates, and that explains about 40% of the increase in emergency admissions by 2009. However, that still leaves about 1/3 emergency admissions unaccounted for. In the chart, we see the proportion of emergency admissions in 2004-5 that fall into each 5-year age band. That's the dark blue on the left-hand side. The light blue on the right-hand side shows that age band's contribution to the increase in emergency admissions, adjusted for age and sex, by 2008-9. And what we can see is that there's no clear set of age groups where that increase is concentrated. Has the case mix of emergency admissions changed? What we're looking at here is a plot showing the top 10 diagnoses of emergency admissions using the same style as the plot we saw in the previous slide. What we see is that the top 10 represent 1/3 of total emergency admissions in 2004-5, that's the dark blue on the left, but they represent 2/3 of the increase in emergency admissions, that's the light blue on the right hand side. Also, they tend to be things that are quite vague, lots of signs and symptoms, and you might tend to associate them with older people, although we see them in other age groups as well. Now, even though this top 10 are overrepresented in the increase, the rise in admissions isn't concentrating itself into any clear group of diagnoses, so it appears that the rise in emergency admissions, just like age groups, is more or less across the board. Do all hospitals exhibit the same patterns? These two charts show change over time for 150 acute hospital trusts that haven't undergone major mergers in the 5 years that we're looking at. The chart on the left shows the year-on-year change in emergency admissions. Very steady year-on-year growth, with the median being 2.7%. The middle 80% of trusts, that's the boxes, are quite tightly distributed around that average, although some trusts are steady at around 0 growth and some are even reducing. The bars around the diamonds show the minimum and maximum range, which shows that in a minority of trusts there are some quite extreme behaviours. These are likely to be the result of service change below the trust level. The plot on the right shows the proportion of emergency admissions that are short stay. That's either no or 1 days. And here we can see there's a very steady rise. The median increases from 41% in 2004 to 49% in 2008. And that middle 80% range shown in the boxes is growing steadily with it. In 2004-5, the minimum and maximum range from 25% to 65%, which shows that there's large variation between trusts in the proportion of short-stay emergency admissions. Are changes in short-stay emergency admissions linked to success on A&E targets? The Department of Health introduced a target that by 2004, 98% of all accident and emergency attenders should be seen and admitted or sent home within 4 hours. It's been suggested that trusts can gain an advantage on this target by, whenever the patient is approaching their 4-hour limit, admitting them to gain extra time to see the patient and treat them without breaching the target. We'd expect that these emergency admissions would result in short stay admissions, as the patient would wait another few hours and then be seen and sent home. So we might be able to see the impact of these admissions in a possible substitution effect between the number of breaches and the number of 0-day emergency admissions. What we're looking at in this chart is the number of 0-day emergency admissions in all England, in the blue, combined with the number of breaches for all England in the red. What we see is a smooth increase in the number of 0-day emergency admissions, combined with a sharp drop in the number of breaches in the early years of the target, which then becomes a constant proportion on top of the rising emergency admissions. What we're looking at here is the same measure for a single trust, and it's a hospital that we think shows a normal pattern of emergency admissions. Again, like England, we see a rise in the 0-day emergency admissions, combined with a sharp fall in breaches that then becomes a constant level on top of the 0-day emergency admissions. This shows the same analysis in another trust. And here there's a big jump in the number of 0-day emergency admissions between Q3 and Q4 of 2004-05. This jump in 0-day emergency admissions coincides with a sudden reduction in the number of breaches of their 4-hour A&E target, and coincidentally this is the first quarter that they managed to achieve the 98% level. There could of course be a number of reasons for this pattern of emergency admissions. Do all areas show the same pattern of emergency admissions? What we're looking at here are two maps of primary care trust area, coloured by standardised emergency admission ratio, which is a measure of the number of observed emergency admissions compared with the number of expected emergency admissions generated by considering the age and sex of people in an area and the level of emergency admissions in 2004 and 5. The map on the left shows the standardised emergency admission ratio for 2004-05, and we find that there's a very strong correlation between the level of emergency admissions and the deprivation of an area. The map on the right shows the change in standardised emergency admission ratio between 2004 and 2009. Interestingly, here we don't find a correlation with deprivation or population migration. Also, there's no correlation between the increase and the baseline standardised admission ratio. We've looked at a number of possible reasons for the increase in emergency admission, and they're shown on the screen now. As with most things, it's likely that multiple factors are behind the observed changes. Some of the most important ones from the analysis we've done include changing public expectations. We've seen that people are much more likely to seek healthcare. Changes in population need being influenced by the age structure of the population, which explains some of the increase in emergency admissions, but not all. And we've also seen a number of across-the-board effects in diagnosis and treatment, which suggests that it's possibly the threshold for admission that's changing. That could be for many reasons, either for clinical decisions becoming more conservative, possibly as part of a fear of litigation, or junior doctors lacking confidence. It could be lack of faith in primary care services to monitor patients, or it could be related to the availability of additional resources and techniques, meaning that more illness can now be detected and treated. All of these factors may well result in the sort of across-the-board increase in short observational hospital admissions that we have found. If you would like to find out more, you can visit the Understanding Trends in Emergency Care section of our website under the Projects tab from our homepage. There you'll be able to read our briefing document on this research, download the full report, or see the notes from our 8th of June 2010 seminar on understanding the growth in demand.